The best advice I ever received was very early in my residency, and these were two simple words that I read from this book by Graham Attlee. And those two words were, fractures heal. Fractures heal. That should make us humble, because what those two simple words tell us is that fractures heal on their own. We surgeons merely guide that healing to a desired outcome. So how has this influenced my treatment of fractures over the last several decades? Let's look at the simplest fractures we treat, metacarpal and phalangeal fractures. The usual protocol is conservative or surgical. Then we put it in some kind of a rigid immobilization like a cast or a splint, often till the fracture heals. But if fractures heal, is this immobilization necessary? It is my firm belief that metacarpal and phalangeal fractures should be mobilized immediately because fractures heal. It is also my belief that metacarpal and phalangeal fractures should be treated in removable braces because fractures heal. In other words, my recommendation is that we need to outcast the cast. My protocol for phalangeal and metacarpal fractures, because I know that they're going to heal, is very simple. I look at them and I decide if they're stable or unstable. In my definition, a stable fracture is one which is incomplete, undisplaced or minimally displaced with no obvious deformity and no obvious malrotation on range of movement. You can accept a little bit of internal malrotation for the small finger. If it is stable, I just put it in a brace with a buddy. And if it is unstable, I take them to surgery and then put them back with a brace or a buddy. And then I commence gentle assisted range of movement because fractures heal. I use a radial gutter for the index and long finger, an ulnar gutter for ring and small finger, and some kind of a thumb spiker brace. For most fractures, if I have to fix them, I use an interlocked K-wire technique, which I published a few years ago. If it's a subchondral fracture dislocation like this, I use a buttress technique, which again was published a few years ago. And if it's a highly comminuted pilon fracture, I'll put a Suzuki frame. What is gentle assisted range of movement? Well, I call it the ouch therapy. The patient is asked to remove the brace and retain the buddy, and then they do an active range of movement till they get a little bit of resistance or pain. And then I say, move one more ouch actively. And then at that point, take your other hand, push it, and move one more ouch passively. Ouch, ouch. 10 minutes, 3 to 4 times a day. For non-operative, I started immediately and it's patient-driven. If it's post-op, it's done 48 hours later, and formal therapy is instituted. So I'm only going to show you non-operative results because operative cases will include replants, tendon injuries, all kinds of a mishmash which you can't really compare. 424 fractures were looked at over a 3-year period. 74% could be treated non-operatively because fractures heal. And the union rate in all of these was 100%. We got excellent or good range of movement in 90%, and we only converted 1.5% of these cases to surgery because fractures heal. Metacarpal fractures, again, a pretty large series. 87% non-operatively treated, all healed, excellent to good range of movement, 94%. None of them needed conversion to surgery because fractures heal. Here are a few quick illustrative cases. Highly comminuted metacarpal fracture, gunshot wound, shortening, bone loss, anything you can think of, non-operatively treated, excellent result, fractures heal. Intra-auricular fracture in a child, treated by an interlocked K-wire. 6 weeks post-op, this is a young child doing her own movement, excellent movement. Already you can see the K-wires are still in place. PIP fracture dislocation, subchondral fixation, 6 weeks post-op, final result, fractures heal. Comminuted pilon fracture, Suzuki frame, heals, 6 weeks post-op range of movement, pretty decent final outcome. Thumb avulsion amputation, you can see the replant level of, actually the reattachment level of the vessel was almost at the level of the nail there, because that's how high the avulsion went. 2 weeks replantation, patient is already moving the finger, 6 weeks final follow-up. Fractures heal. Mangled hand, I did not even know which tissue was which. I had to look at it and figure out that I've got to make something using bits and pieces of everything. You can see there's tendon in one finger, bone in one finger, skin in another. Used all that, created a pincer hand, interlocked K-wire, started moving the patient. But now this particular patient, I had to modify the protocol because he developed PTSD. He became depressed, demotivated, so I allowed him to start using the hand even before fractures united. That's the patient using that pincer with the K-wires in situ. So treat the patient, not the hand. Two simple words: fractures heal. We surgeons merely guide the healing to a desired outcome. Thank you very much.